Hi, good afternoon, everybody. I'm Dave Stalker, the president of EuropeActive, and want to welcome you all to today's webinar. And you have the title there in front of you. I'm going to start, although I can see there are people coming in the room, but there's lots to cover and some fantastic guests with us today. And I'd rather that we cracked on and got into the information. Before we move to that, which is the most important part, is the experts who are here to speak to us. I just thought that it was worthwhile just going through a couple of things from EuropeActive's point of view in terms of this specific area and our own strategy documents, so it sets a scene of where EuropeActive is going. So Robbie, if we could go to the next slide. So this is our initiatives under our strategy in terms of our repositioning, and sort of in this regard we will launch our permanent CEO advisory board, which will be the President's Council, which consists of the leaders of Europe's largest club operators, and this is with the aim to help EuropeActive reposition the sector towards public health and our positive impact on the physical, social and mental well-being of our communities. It's only possible to do the work in this area with the support of these people, both financially, intellectually, and in the ability to open up doors across Europe. Great, Robbie. Added to that, we will also are setting up a new scientific advisory board, and that's a think tank for fitness and physical activity, which will oversee the development of what is our current knowledge centre, hopefully into a European think tank for fitness and physical activity, which will be of central importance, working with the President's Council on positioning our sector towards public health policy and understanding those public health challenges, both across Europe, but also nationally. And finally, in terms of where we're going on that next slide, another goal will be organising our annual European Medical Fitness Summit for stakeholders, and hopefully leading the debate on fitness and exercise for medical and healthcare purposes, gathering and engaging sort of relevant academia, healthcare professionals. There's no shortage of both those set of people even on this webinar, insurers, national association, public authorities, decision makers, as well as our sector operators and suppliers. In this sort of one-off opportunity that this pandemic has given to us, this is our opportunity to hopefully have an impact at the top table and show what a difference we can make as a sector and how we can work in partnership without standing on the toes of others. So on the next slide, Robbie, I'll let Julian Berryman, who I'm sure you all know, do the introductions of people. But we all know we need a high level of credibility if we're going to be a trusted partner of the health sector and offer a preventative solution to those both non-communicable and communicable diseases. And so as part of this, we're going to continue to professionalise our workforce. And that's talk about graduate level roles, working, whether it's with the US, with ACSM and all these various bodies. And I think that this session for me, hopefully will provide an insight into how these roles and how we can develop at the European fitness and physical activity sector continues to professionalise. And hopefully we take that rightful place I spoke about in European society as important providers. So rather than waste time with me talking about EuropeActive's vision, I'm going to hand over to Julian to introduce what I believe and see is just a fantastic panel. Over to you, Julian.
Thanks, Dave. Fantastic. Yes, I think it is a fantastic panel. I'm Julian Berryman. You may know me. I'm the director of the EuropeActive Professional Standards Committee. So I deal with all things educational, skills development, that side of what we do, and hence why I'm introducing our speakers today. But I want to give them plenty of time to talk, and I think we've got some really interesting insights into some of the higher level graduate-based roles that are developing, have been developed, are being developed around the world. And clearly I would want that to inform our own pathways, our own sector qualification framework, our EuropeActive educational standards. So 3 panelists today. We have Francis Nerrick from ACSM. We have Dr. Andrew Scott from the University of Portsmouth in the UK, and we have Dr. Kay Davison from University of South Australia. I'd like to thank Francis and Kay, particularly for joining us today at what is, as you could guess, a fairly ungodly hour for them. Yes, very much appreciate the input. We're going to start with Francis Nerrick from the ACSM. Francis is the National Director of Certification and is going to talk to us about his, or the ACSM Exercise Physiologist Certified Clinical Exercise Physiologist roles. Over to you, Francis.
Great, not a problem. Let me see here. Can everyone see my screen?
We've got it.
Okay, very good. Hi, so my name is Francis Nerrick. I'm the National Director of Certification here at the American College of Sports Medicine. While I oversee the development of the certification programs, I also sit on the boards for the Committee on Accreditation for Exercise Science, or that's academic accreditation, and I also sit on the board for the Coalition for the Registration of Exercise Professionals, which is related to the US reps as well. In terms of scopes of practice for certifications, we have 4 core certifications for the American College of Sports Medicine: group exercise instructor and personal trainer, exercise physiologist, which is you have to have at least a bachelor's degree, and a clinical exercise physiologist, which is either a bachelor's degree with 1,200 hours of experience or a master's degree with 600 hours of experience. When you're looking at the certifications in series, the higher the education you have and the more experience that you have, those allows you to work with a variety of clients. So with a high school diploma or vocational education, you're working with low to moderate risk clients. Low to moderate could be potentially a client with who's pregnant, right? So the more professional education you have, you can certainly extend your blue bars there. For exercise physiologists, you have to have at least a tertiary degree. So you have to have a degree in exercise science or exercise physiology. This one is you're working with moderate, from healthy clients to moderate risk, but also on these ones, you're working with individuals who've completed potentially a cardiac rehab program. So they've completed it, now they want to continue exercising, and so they're of higher risk, but not high risk. The clinical exercise physiologist works primarily in medical-based settings. So these are the ones who are working at a hospital, working with a variety of diseases and conditions. And I'll show those in a later slide. In terms of growth in the profession, for the fitness sector, the US Bureau of Labor Statistics is looking about a 13% growth in the sector. This is pre-COVID, so and this was done in 2018. You can see the median salaries and pay there, and about the number of jobs is about 356,000, 357,000 jobs that are in the US. In terms of the clinical exercise physiologists, they make a little bit more money in terms of job growth that they see from in the next 10 years, about 10% job growth in that sector as well. And again, this is a medical-based fitness. So in terms of giving quick background about our certification programs, we do what's called a job task analysis every 5 years or so. And this is a large-scale survey of practicing professionals. And so those are the ones who are an exercise physiologist or clinical exercise physiologist. And what we do then is once we survey them, let's see. What we are, the purpose of doing a job task analysis is really to determine what are the critical knowledge, skills, and abilities for you to be able to do a job, right? So not whether you're educated or not, it's just whether you can do a job, right? So those are and to be able to do it safely and effectively. And the purpose of the certification piece is really kind of for public protection, right? We're not beholden to the university, we're beholden to the public. So this is where it's, what are those critical knowledge, skills, and abilities to do your job? As part of this report, I'm going backwards a little bit, I had it reversed. We put this report out that's confirmed by also a panel of experts as well. And this is freely available to anybody. It's about a 19-page report for each certification. Within the exam content outline, we put in each knowledge, skill, and ability that you have to be able to do to practice your job. But what is important in here, starting in 2017, we started to add in cognitive complexity in here as well. So we use a modified Bloom's taxonomy to assign cognitive levels. And so we use recall, application, and synthesis. Recall being the lowest level of cognitive difficulty, and synthesis being the most difficult, right? In terms of the exercise physiologist certification with a bachelor's degree, these are individuals who are advanced health fitness professionals. They work in a variety of settings, which include university, corporate wellness, medical fitness centers, military fitness, and community-based settings. So these are individuals that can work both on the healthy side and then also those with moderate risk. So that what is important to understand here too is that they can do advanced assessments as well, like VO2 max tests, because that's what they learn in university. In terms of content weighting on the exams, 35% of the exam is related to health fitness assessments, 35% is on exercise prescription, 25% on exercise counseling and behavioral modification, and 5% on professional responsibilities. So that's how the breakout of the certification itself, what's covered on there. In terms of the clinical exercise physiologist, as I've stated before, there's two entryways to get into the clinical exercise physiologist. It's a bachelor's degree with 1,200 hours of experience, or about a year of experience, or a master's degree with 600 hours of clinical experience. Most of our clinical exercise physiologists have a master's degree. While we have the bachelor's level that's there, about 70% of our clinical exercise physiologists have a master's degree. So these individuals are working with individuals with unstable disease or conditions that are chronic, and it's cardiovascular, pulmonary, metabolic, orthopedic, musculoskeletal, neuromuscular, neoplastic, immunologic, and hematological diseases. So those are the types of diseases and conditions that they're working with. In terms of breaking out the hours, these are recommended, not required. These are the recommended weighting of hours based on practice that you'll see in as a clinical exercise physiologist. You can see that obesity and metabolic and cardiovascular are the ones that seem the most, and then behavior change and education are also are important qualities that our clinical exercise physiologists need to be aware of. These are, again, recommended, not required. In terms of content weighting in the assessment, patient assessments 20%, exercise testing 19%, exercise prescription 23%, exercise training 23%, behavioral modification 10%, and legal responsibilities 5%. So it's a little bit different. So quite a bit of this is really kind of training and educating our patients as well. In terms of the technical requirements, when we're looking at certification, and our board is keenly interested, our certification board is keenly interested, and there's really kind of 4 areas. And I think this is where Julian was really kind of describing, is that being recognized by healthcare providers, physicians, physical therapists, et cetera. There's really kind of 4 key components that you would need, at least in the US, that we've understood. Number 1 is accredited education. Bar none, this is one of those things that's it's really critical for you to prepare for the job of an exercise physiologist or a clinical exercise physiologist. In terms of the accredited education piece, what this really means is you successfully completed a formalized education program that prepares you specifically for a job. That is really critical. Professional certification ties number 2 and 3. So this is independent verification of whether you can do the job safely and effectively, independent of how you were educated. Number 3 is continuing competence. How do we know and you're assuring to the public that you keep up with the current standards and guidelines in the profession. And the fourth one is professional registry. And a couple of key things in the professional registry is verifying whether those credentials are current. The second one is really kind of, which is important too, is a formalized disciplinary process. So if somebody performs some sort of felonious behavior, or somebody like is unethical, how do you know where they're practicing, and how do you pull them from the registry as well? So those are the four key components. For certifications, I think there was a couple substantive changes that we've done. Number one is merging the clinical certifications. We used to have two clinical certifications. One is called a registered clinical exercise physiologist. Another one is a clinical exercise physiologist. And a lot of the employers and candidates had difficulty understanding the difference between the two. So we put them, so we moved forward with only one clinical exercise physiology program. The registry is moved over to really identifying who the person is and where they're practicing. From the cognitive complexity side, this is again being able to provide additional information to universities of how they should teach, or not necessarily how to teach their programs, but is providing better guidance into how cognitively complex they need to instruct their students on certain job tasks. And the last one is reducing variances. One of the key things for ACSM moving to the future is that looking at exercise science programs, right now it is not required to graduate from an accredited university that's recommended. But how our certification board has really identified that there's a lot of variances between college universities that say they're an exercise science program. So we're looking for opportunities to shore up and make sure that those who are graduating and are taking the exercise physiologist or clinical exercise physiologist programs are adequately prepared for the job. And the last one is being able to have a consistent job of clinical exercise physiology. So if you work in the United States or in Australia or the UK or in the European Union, when we say you're a clinical exercise physiologist, we're talking about the same thing. That's a key thing that our certification board is keenly interested in pursuing as well. So I will stop there and see if there's anything else you would want me to cover, Julian.
Okay, lovely. Thank you, Francis. Just to take this opportunity just to say, because I didn't mention it at the beginning, that audience, please, if you have any questions, please post them in the Q&A section at the bottom of your screens there, and we'll try and come to those questions probably at the end of everybody's presentation. But please feel free to ask them some questions there. Yeah, really interesting, Francis. I mean, you go through quite a similar process to us in terms of developing a set of standards around a job task analysis. So we identify a job role, and then it's about identifying learning outcomes that actually allow that person to do that job. So you're obviously going through through quite a similar process there. That was the question that was occurring to me, that with the yes, you need a bachelor's or a master's, but I guess there are universities that accredit themselves against your clinical exercise physiologist standard, your exercise physiologist standards. Is that correct?
Similar. So when we develop professional certifications at ACSM, what we do is when we identify with those critical knowledge, skills, and abilities and cognitive levels of cognitive complexity, we provide those to university, and we allow the universities to be able to teach to what those expectations are of both the public and then also expectations of employers. So those are the things that when we're looking at it from that perspective, it's really critical that we don't force a university to do that. We just we put those as an exam and outline. What we show is this is what expect you to be able to do it safely and effectively. How the universities go through and teach to that standard is up to the university. However, knowing that universities, when they're able to teach their own curriculum and put their own course classes together, there could be variances between what one university does versus another. So that's something that we're going to be addressing here pretty soon. Okay,
lovely. Thank you, Francis. Your signal is not great, so but hopefully it'll improve when we come back to the questions. Okay, so let's move on if we can. So that's the clinical exercise physiologist role in the US, ACSM. Now we're going to move down to Australia, and Dr. Cade Davison, who is the Program Director for Clinical Exercise at the University of South Australia. And I think also Cade is associated with ESSA, the Exercise and Sports Sciences Association in Australia. Over to you, Cade, if you'd like to talk about the roles that you've developed down in Australia. Thank you.
Yes, sure. Thank you, Julian. You can see my screen okay, can you?
Yeah.
Great. Okay, so look, I've taken on the brief and I will attempt to give you a little bit of an insight into how the system functions in Australia and factor in some of the considerations around and opportunities that we see evolving out of this interesting pandemic crisis that the world is going through the throes at the moment. Factor that in. So I'll start by just, I guess, introducing how I'm here and my interest. So I recently stepped off the board of Exercise Science Australia after 11 years, and the last 3 years in the president role, vice president before that. So I've had quite a bit of, I guess, insight and input into the evolution of our system over that period. Still quite closely connected, so I was really excited by the opportunity to come and hear what's happening in this forum and contribute to it from our perspective. I'm also been in my retirement from ESSA, given the opportunity to represent ESSA on a newly established body, International Confederation of Sport and Exercise Science, which I've been involved in my ACSM representative position, and some colleagues of Andy, Bases, so we have Canada, US, UK and New Zealand, all of Australia, Federation. So very interested in what's happening, what's evolving around the world. I have a research interest in industry models of exercise medicine, lots of interest in Australia and work particularly here, but also looking at how that functions in other parts of the world. And I'm a passionate educator and practitioner of exercise as medicine, and again, interested in opportunities and growth of our industry. A little bit of insight into the system in Australia, and I can see there's definitely some alignment with the US, and it probably sits similarly to some of the models that you're talking about and thinking about, UK and Europe. So my association has been with Exercise Sports Science Australia, and I draw this distinction that that we as an organisation represent only the bachelor degree qualified and above exercise practitioners. So Fitness Australia is sort of our partner organisation in Australia that run the REPS scheme in Australia. So we have this qualification framework with certificate level. This is sort of the vocational technical skills training. The certificate 3 level gets a gym instructor or group exercise, and a certificate 4 as a personal trainer. Our accredited exercise scientist, which is something akin to the ACSM exercise physiologist, non-clinical, is minimum bachelor degree. And then we have the accredited exercise physiologist, which is minimum a bachelor honours degree in the Australian system, which is a 4-year bachelor, or more commonly a coursework master's program. We have had some as a graduate diploma, but they've tended to be phased out. So we've really got this 4-year bachelor model, or a 3-year bachelor exercise sports science plus a 1.5 to 2-year master's to get the accredited exercise scientist. We have similar but not quite the same processes around setting of standards, which I can go into in Q&A if people are interested, but I won't explore that in detail in my presentation. And we do actually accredit universities for at these levels. So someone must, particularly at the accredited exercise physiologist, the clinical level, someone must graduate from an accredited university to eligible. There's no other pathway to become accredited, and that's the same for equivalent 4-year professional qualifications like health Australia, like therapy, occupational therapy, medicines. Years you must graduate from an accredited degree to be eligible. Our professions are defined by scopes of practice. So I've pulled this from, obviously I have not had anything to do with this personally, but Fitness Australia have a scope of practice for the Australian reps, the registered exercise professionals, and they have a scope, I guess, that defines the exercise medicine space really by exclusion. So their registered exercise professional scope does not include therapeutic treatment or independent, so to move my little people box, independent rehabilitative exercise prescription or independent exercise prescription for high-risk clients. So somewhat in the ACSM model. That's excluded from the scope of the vocationally trained qualifications. When we move to the bachelor qualified exercise scientist model, we have this is an inclusive scope. The scope here that's relevant to this is 2.3 to the supervision of exercise programs for clients with pathology or injury that have been prescribed by an appropriately qualified health professional, such as an accredited exercise physiologist or physiotherapist. So this level there is, again, this is probably the equivalent of bachelor qualified exercise physiologist in the ACSM model. This is opportunity to work with clients with pathology but not individually prescribe. So they're working in the area of management and secondary prevention of illness, but only under the guidance of stable clients, under the guidance of a program that's been prescribed by an accredited exercise physiologist or physiotherapist as appropriate. We move to the accredited exercise physiologist scope of practice. So this one then explicitly by inclusion, specifically most of this refers to the management of clinical exercise as medicine, clinical interventions of exercise, but particularly the ones I've highlighted here: provision of clinical exercise prescription for those with existing chronic and complex medical conditions, provision of exercise-based rehabilitation and advice for patients in the acute, subacute stage, injury, surgical intervention, or during recovery to restore functional capacity. So this specifies the role of the accredited exercise physiologist in that high risk existing pathology management, treatment, and secondary prevention space. We have a exercise screening, pre-screening system, as most countries have some model of this. So we have a screening system which we've got actually really good collaboration. So we've got the Exercises Medicine Australia, Fitness Australia, Sports Medicine Australia, and Exercise Science Australia collaborative screening model here. It's recently updated. This is the system whereby we identify immediately that risk classification that defines who an individual should be working with. It's quite a complex flowchart here that I won't go into in detail, but essentially it allows referrals to come in at different levels from different areas. So people may be referred for exercise by their GP, which might be by specific medical referral under a compensable insurance scheme directly to a clinical exercise physiologist or an accredited exercise physiologist, for example. Or it might be the GP telling someone they need to do more exercise, so go and have a chat to your local gym, in which case we might call that a GP or something like a self-referral. We've also got where people may be referred under a workers' compensation scheme, or another health professional, so they can enter into their journey with exercise at any of these points and be seen by anyone across the spectrum. At the exercise scientist or the personal trainer level, then they would be running this pre-exercise screen and essentially classifying people by risk stratification and looking, do they have any pre-identified risk if or are they? The question is in the reverse. So are they clear? If they're clear, yes, then they can commence or continue exercise. If they're not clear, then they're referred. One thing we tried to do with this model was to take out the idea where people needed to be sent back to their GP. So we had this silly situation where a GP says someone needs to go and do some exercise, and then the gym screens them and says, well, we actually need to go back to your GP, get clearance to do exercise. So we've introduced this level where the exercise physiologist can be the intermediary there. They can then screen that person and say, is there in fact some pathology that needs to be medical education, or do they just need a level of supervision of the existing, or can they be prescribed a program that can be supervised? So there's a different level there, and clarifying roles in that model. To bring in this interesting COVID situation that we've got, the interaction between COVID, long-term impacts of COVID and the potential for exercise medicine to intervene. So seeing more reports or more every day, I think of things like
Cade.
Sure.
Sorry, could I just interrupt you there? You're over 9,000 miles away here, and your signal is unfortunately not great. Please, audience, bear with us on that. I think we're getting 80% of it, Cade, but we miss a bit every now and again. I don't know if this may sound daft, but it almost feels like if you talk a little bit slower, it's not so bad.
Sure.
But, yeah.
Sure. Yep.
Give it a try. Give it a try.
Yep. I'll try and speak more clearly. I've just checked my signal looks quite strong. So long-term impacts of COVID and potential for exercise to intervene. We've heard stories of impaired pulmonary function, scarring. So people that are becoming quite ill are getting some permanent damaging to pulmonary function. Some evidence of cardiomyopathy, damage to heart function. There's an issue around post-viral fatigue of serious viruses. We might see worsening of existing illnesses, so people that are more susceptible, but also potentially not accessing their normal medical treatment. So people with cardiovascular disease, type 2 diabetes, cancers, and osteoarthritis. Big issue locally around the impact on people's service. Issue around the safe return to exercise facilities. So I talked about that idea of the screening with different aspects around screening. We're looking at infection control measures, and also some interesting opportunities around the health funding system. This is a result of the economic impact, but also the way that we're changing the way that we're delivering health in certain ways in response to COVID. So all of these areas is good as the opportunity of well-qualified exercise practitioners to make impact and make a difference. I'll just run through my signal coming through, right? Julian, you can that?
It's not great at the moment, Cade, but please continue. It's fine. We're getting the sense it's fine.
So we have. We're very fortunate in Australia in that we've had good penetration of the medical system with exercise. This is an article from the Australian Journal of General Practice that was a special article on exercise is medicine, recognition from our medical colleagues of the role of exercise, an editorial here talking about the unrealised role of exercise by a professor of general practice particularly in some areas I talked about in the longer term. We have this set of standards for rehabilitation medicine by the Royal Australian College of Physicians and the Faculty of Rehabilitation Medicine, where they've defined the relative level of involvement of different professionals across different types of rehabilitation. We can see that we have the exercise physiologist listed in this medical guideline, to say, particularly in the orthopedic and in the reconditioning space, that there's moderate requirement for exercise physiology involvement. We've got clear recognition in the cardiac rehabilitation. So this is the cardiac rehab team, will comprise of members including an exercise physiologist. A couple of other documents. This is our national government public health insurance scheme, group services for people with type 2 diabetes that must be delivered by either a diabetes educated dietitian or exercise physiologist. And recently we had the Clinical Oncology Society release a position statement on the role of exercise in the management of cancer, which includes the necessity for patients to see either a physiotherapist or an exercise physiologist for individualised management as part of their cancer therapy. Big issue in Australia. So we've not been hit nearly as hard as much of the rest of the world with COVID numbers and fatalities. We have experienced the heavy lockdown, some current second wave in the city of Melbourne here. We've got people locked down in these high-rise, high-density housing towers, people with drug and alcohol abuse issues, pre-existing mental disorders, lots of refugee, new arrivals. So vulnerable populations that have been locked in their houses by police and military, exacerbating the underlying or bringing forward mental disorders. Very active in promoting the role of exercise in managing mental disorders. So we have award-winning education documents here released by a subsidiary group of Exercise Sports Science Australia. We've got position statements with psychiatrists around the role of accredited exercise physiologists in managing people with mental illness, and a joint position statement here between ACSM, BASES, and again New Zealand on the role of exercise and physical activity in reducing the life expectancy gap for people with mental illness. So this is a very significant issue that we're working hard to lobby with our government for access to exercise for people with mental illness, again exacerbated by the COVID pandemic. Another interesting final point is an interesting opportunity that's come through the activation of telehealth. So we have not had access to funding for telehealth as a profession, but through COVID, there has been provision for all allied health professionals to provide services through telehealth. So we're lobbying hard at the moment, along with our allied health colleagues and general practitioners, to maintain the opportunity for telehealth services in some really interesting, innovative ways that people are delivering exercise-based services through telehealth platforms during the pandemic. So to conclude, advanced level qualifications, clear role delineation, and appropriate screening referral systems needed to support exercise medicine. There is a significant opportunity for exercise practitioners to aid in the recovery worldwide from COVID-19. Lots of areas for interaction. And there is an opportunity through new models of health service delivery. I think every government has an economic cost of COVID that needs to be more cost effective in the way they deliver health services, and primary and secondary prevention through exercise. A lot of money, as we all know, in hospitalisation and exacerbated disease. That's it. Thank you.
Lovely. Thank you, Kay. Thank you. Fantastic. Fantastic to see the level of recognition of the accredited exercise physiologist in Australia by both the medical profession and insurance, and what you're referring to there in terms of that situation where the person just gets sent back to the PT, but now you have that sort of intermediate in the accredited exercise physiologist who can step in and make an informed decision there. So yeah, fantastic. Shane, you were breaking up a bit, Gabe, but we got through it, and I hope the guys got a good sense of that. Thank you. Our final presenter today, Dr. Andrew Scott from the University of Portsmouth in the UK, and he's going to talk about his efforts, which I'm quite familiar with in terms of developing these kind of roles on a UK and European level. Over to you, Andy. You're on mute, Andy. I think you're on mute.
Yeah. Sorry, I've got a steam-driven laptop as well. There we go. Okay, yeah, thank you for joining us all this afternoon. I'm going to speak a little bit in relation to what Francis and Cade have just spoken about. We're not as well progressed as USA or Australia in the UK, so I'm going to talk about how we are trying to catch up with what America and USA are trying to do. I'm from University of Portsmouth. I'm the course leader for the Clinical Exercise Science program in Portsmouth. I set up the program 10 years ago in 2010, a couple of years after joining the school. And just in case anyone's under misapprehension, that is Portsmouth in the background. It's not Dubai. We seem to have copied the tower in Dubai that's our Spinnaker Tower that was put up for Millennium. And I started up the program similar to the master's degree in John Moores University in Liverpool. We both brought ours online in 2010 by accident together, and ours are still going as a going concern. How I set that program up, I set it up because we have obviously a growing population number in terms of sport and exercise science graduates, and they can't all become the strength and conditioning coach at Manchester United. So we needed to diversify where these students would be progressing to in terms of their careers. And I wanted to set it up with placements in mind. And then in 2015, I decided I would, as well as teaching the master's level clinical exercise science, I use the term clinical exercise science for our course. Clinical exercise physiology is the internationally accepted term for it, but we believed in Portsmouth that the combination of the physiology, the biomechanics and motor control, and exercise psychology and strength and conditioning aspects that are required probably by definition lent themselves to clinical exercise science. But obviously clinical exercise physiologist is the accepted title that more generally we go by everywhere. Really. So as well as combining the master's level learning and the placement learning that I had access to in Portsmouth, I decided to reach out to some partners to co-teach some aspects of the module. So not only do we have clinicians teaching on the course in Portsmouth, we have in their areas of specialism, we also have we had the specialist exercise instructor courses that we have available in the UK that I'll talk about very soon. And on the basis of my role at Portsmouth, I was invited to become the chair of the BASES Clinical Exercise Science and Practice Interest Group that we try to promote in the UK to develop our profession similarly to what Francis does in the USA and Cade and Essa do in Australia, and obviously where we are on catch-up. So I want to quickly rattle through some obvious details really relating to why is there a need for clinical exercise physiology as a profession. What can we do to develop it as a profession in those countries where it's not currently recognised? The subtle differences or not so subtle differences between what's a clinical exercise physiologist and what are specialist exercise instructors. We have both in the UK. similar to how Cade was describing. And then how do we progress this forward? And we have at least one good example of an interprofessional working group called the BACPR Exercise Professionals Group, which I'll quickly finish off with in the end. All of this on this slide goes without saying, really. We've got an increase in proportion of young people who are less active and have access to an energy-dense diet than perhaps we had when we were younger, which is causing morbidity to occur at an earlier age. Exercise profession generally isn't accepted as a healthcare profession around the world. There's only a few countries that I can think of, such as Australia, Austria and Germany, where the exercise profession is incorporated into routine healthcare delivered by exercise physiologists rather than other healthcare professionals. And lastly, sport and exercise science outside of those countries quite often is taught with a sport focus and not always with an exercise and health focus, with the populations we are working with being quite key. A certain level of reorientation of those programs, or at least a greater availability of master's programs to convert such training, because it is relevant, is important. So we've got issues in healthcare from a lifestyle medicine perspective, because the drugs don't work, and not forever at least. We also have issues in our training in higher education. I think this is broadly across the board in what I would call academic programs. So academic programs where the main aim of the program is to develop somebody intellectually, and then hope by some chance of osmosis, they may well retrain themselves after their degree or during their degree to become trained to be able to deliver exercise to the same quality that a well-trained personal trainer might do, for example. Unless there's hybrid courses where the vocational aspects are treated as equally as the academic aspects of the criticality of thinking and being able to access the evidence base that an academic degree delivers, unless we find a way of combining the two, this goes for any sort of sport and exercise science degree, we'll struggle. And that really prepares people for experiential learning. I'm still the placement lead in our school in Portsmouth for students going out into placements. And the biggest challenge I find in placing students is bridging the gap between the academic aspects of their degree and helping them to become confident and competent in placement. Often there's quite a large gap between those, and obviously having an accredited degree and an accredited experience pathway like ACSM and ESSA have, that helps to bridge that gap. I don't really think I need to go into what a clinical exercise physiologist does too much, but what distinguishes a clinical exercise physiologist from a specialist exercise instructor generally is that they've got a degree, probably a master's degree, and on those degrees those individuals will have studied the evidence base for exercise. They'll have studied in depth about medical treatments and the medical conditions themselves and how they affect how someone will function either in exercise or how exercise affects those conditions, and being able to appropriately monitor and evaluate those exercise programs and use tools with knowledge to assess those outcomes. Whereas generally speaking, an exercise instructor wouldn't necessarily have a degree, and they may not have multiple hours. Look here in terms of clinical exercise physiology in USA and ACSM and even UK with BASIS accreditation, over 500 hours of experience, direct experience are required. So in terms of accreditation, there's quite a large degree of difference between an exercise physiologist and specialist exercise instructors, which I'll come on to soon. This is an example of the range of conditions and sub-conditions within the characteristics who an exercise physiologist and even a specialist exercise instructor may be involved with supporting through exercise to not necessarily cure their condition. Obviously it's possible in some instances, but largely to help manage these conditions throughout the person's life, not necessarily to extend their life, but to improve quality of life at the present and into later years as well. In the UK, ESSA have kindly given us permission to extend their professional standards into the UK so we can develop our educational pathway and accreditation and hopefully run it similarly within a few years similar to what ESSA are doing across their degrees in USA. And these are just some of the scopes of practice, as I mentioned earlier, that might be presented by someone who is trained in clinical exercise, having gone through an appropriate degree pathway. I'm largely repeating what Francis and Cade would have said there. It's really important, and I've spoken with Francis about this previously, we can't just translate what ESSA do or ACSM do into the UK, and this would be the same for Europe. One of the things that stops the clear scope of practice being translated into the UK is our professional standards in terms of the UK, what's accepted in the UK Health Service, our National Health Service, to be incorporated as an allied health professional. So these are some examples of overarching professional standards or proficiencies that are expected in our healthcare professionals in the UK. And obviously we've just inserted clinical exercise into these, but these are the professional standards you might see for a clinical physiologist or a physiotherapist in the UK that a clinical exercise physiologist would need to be aware of besides just the exercise proficiencies as well. I've copied these again straight from ESSA's professional standards. ESSA have a few pillars or core professional standards that are required of their clinical exercise or exercise physiologists as they are in Australia. So as I said earlier, there's importance placed upon baseline foundational knowledge of professional practice relating to medical conditions and how they are treated, and also knowledge of the evidence base and how to apply this in the context of monitoring and evaluating and implementing exercise interventions in people with long-term conditions. There's requirement for professional practice in demonstrating quality assured practice, so practicums. These are core parts of the training in USA. In Australia. In USA, these might be part of a master's degree, or they may be part of a graduate's ongoing training post-degree. We need to think about methods of how we incorporate these into our programs, either within a program or have an accreditation pathway, such as possibly what EuropeActive might quality assure, to make sure that when exercise physiologists are practicing and have a certain level of experience on their CV, that it's accredited and accounted for in some way. Need to have knowledge and ability in receiving referrals. So in the UK, we have our confirmed referral pathways in cardiac rehabilitation, pulmonary rehabilitation, falls prevention, even increasingly in cancer now. So we've got these referral pathways from hospital to community, but there's a big gap in there where an exercise physiologist is needed to provide alternative services to those that a physiotherapist might provide in a musculoskeletal context, and maybe even providing the conduit in terms of prescribing exercise that a personal trainer could then deliver in the community. Designing exercise interventions form part of that, and then actually methods of implementing exercise interventions in practice. And increasingly now, not only am I being asked to deliver this seminar online, rather than travel to Vienna or Ghent, which is where Julian and I last saw each other, we've got opportunities now to be delivering these interventions by distance. So in the UK, we have a safe fit trial that's set up where people who are being treated or have been affected by cancer and now receiving personal training from someone in a completely different part of the country because they've been identified as an appropriate physical or personal trainer for that client. So certainly online deliveries, as Kate alluded to, is providing us with a great opportunity for intervening with people and mainly keeping a social interaction with them. I mentioned earlier that Germany was one country in Europe that actually has an accreditation pathway for exercise physiologists. So the German Association for Health, Sport and Exercise Therapy, that's the DVGS in Germany, they have their pillars of healthcare, and they will license exercise physiologists to specialise in one of these conditions below. The 4 pillars used to be just cardiac, respiratory, diabetes and osteoporosis, but increasingly, because we know that exercise is not just complementary therapy in cancer, but it is direct adjunct therapy to improve outcomes in cancer, that's essentially the 5th of these four pillars now. And if someone was well trained, they could be licensed in all of these if they took the licensure for each of these healthcare pathways. This license is either delivered through an accredited university, or if a student attends a non-accredited university, the DVGS will license those graduates directly as long as they pass their assessment exam, very similar to the ACSM method. So there's some flexibility there, but the exercise therapies is well accepted in Germany as part of their healthcare system. An interesting development that I came across a few years ago, and this is really of interest to universities in Europe that are interested in working together. Sadly, the UK are about to miss out on the Erasmus programme that's delivered through the EU. There's a European Master in Health and Physical Activity, and it's a master's programme that's coordinated through Foro Italico in Rome, and it involves these 5 universities across Europe. Now, this European Master is about preventive healthcare. So using physical activity as a tool to improve health in people who might be at risk of developing health conditions. I think it's quite qualitative in nature rather than clinical exercise physiology. But if you're interested in clicking on this link and looking further, it's got a really good website. This is something that could be adapted into a European-wide clinical exercise physiology program. If any European university out there is obviously listening to this webinar, I would urge you to look at this program to see if it can be replicated in a clinical exercise physiology context. Okay, so that's the academic higher education aspect over with. Kate's already talked to us about the international confederation involving these organisations. ECSS is the European College of Sports Science, is certainly an organisation that's missing from this list. So again, if anyone's representing ECSS on this webinar, it may be wise to get in touch with Kate to see whether there's a spot on the roster, to see whether ECSS would be interested in joining this international club. Lastly, to finish off with, clinical exercise science in the UK, or clinical exercise in the UK, is very well developed in terms of its instructor training. So most of the clinical exercise that's delivered in the UK, certainly from anyone who's accredited in any way, is delivered by organisations associated with BACPR, the British Lung Foundation, Anna Campbell's Can Rehab training organisation, or Professor Dawn Skelton's Later Life Training. We have this pathway in the UK, and it requires levels of training and levels of experience between that training. So this is a diagram that I took from my book from a few years ago. Someone is trained in baseline fitness teaching, and then they gain experience and then apply that teaching in an exercise referral context. An exercise referral in the UK is where people are referred from their general practitioner, and they are provided with exercise to improve their hypertension, to improve their type 2 diabetes, to manage their osteopenia, to manage osteoarthritis, for example. So people who are at risk of developing high-risk conditions, so that when they've gained experience in those conditions or delivering exercise for those conditions, they can then specialise in exercise for people in cardiac rehabilitation, pulmonary rehabilitation, exercise in cancer, or exercise for older people at risk of falling. I incorporated all of these into the master's degree that I developed into a coherent program to develop professionals to deliver exercise in the UK framework. So in the UK, this is definitely the most progressed system that we have, and I think it would be a really good idea for EuropeActive certainly to look at this model to see how it could be packaged in a European context, really, to make use of what's there, certainly at the higher levels. Very last slide here. This is just more of a, I suppose, political or change making. One of the good things that we've done in the UK, the BACPR, British Association for Cardiac Prevention and Rehabilitation, developed their exercise professionals group way back in 1999. So it's been going for 20 years now. And rather than them saying, our exercise professionals are the best trained to deliver exercise in hospitals, they brought together their physiotherapists, exercise scientists from BACES, and their well-trained fitness professionals to develop this exercise group. Because in a nutshell, they developed their exercise training for the community, so after hospital referral, and they were finding that the fitness professionals were better trained than the hospital-based health professionals. And they needed to bring together a group to make sure that that richness of the training and experience was provided in the hospital where it was needed. So there was the need to develop this three-pronged exercise group. And this group is still going strong. It has its training days. It has an annual conference. And really what we need to do in the UK is to develop this group to include wider population groups. So we bring together what's called the exercise family. And if we bring together that exercise family, hopefully by developing clear scopes of practice for what a physiotherapist should do, what an exercise scientist or physiologist should do, and what a exercise professional should do, it stops toes being stamped upon and people feeling like their noses have been put out of joint. And I'll just leave you with my summary there.
Okay. Lovely, Andy. That's a nice note to finish on. I think we've gone over our hour slightly, but maybe if I can just conclude and maybe weave in a couple of thoughts and maybe even a question or two. Yeah, I mean, I guess that's a plea that we should all sort of work together in this. That our exercise scientists, the allied health professionals, physiotherapists, but also fitness professionals all have a part to play in this. But everybody needs to be aware of their scope of practice and to be working. You talk about stepping on toes, working within that scope of practice. And because the whole thing, I guess, falls down if there isn't an established pathway and there aren't established relationships. So, I'm thinking of that situation. Does every personal trainer, are they, would they refer in Australia or in America or even in the UK to that higher level individual, or would they try and deal with that individual themselves, or what are the processes that underpin all of that? You've got to get the buy-in of the industry. The other thing that the European Masters, Andy, great for highlighting that. I think that's something we really need to look at, and we are looking at. So we'll talk to you about that one. What else did I want to say? That's it. The other really interesting point for me was what was being said there about that mix of the higher educational and the vocational aspects. And I'm a firm believer in the value of both of those things. And it does seem to be a bit of a shame that in many cases we don't address both of those things. So the university education maybe. Oh, that was a fly landed on my screen. Good grief, that's strange. The higher education is very academic, maybe doesn't speak to the vocational. So as you've done in the UK, Andy, to weave in those vocational elements within that academic degree, you're producing some fantastic people there, and that has to be our ultimate goal. Is there a question in there? I'm not sure there is. That's just a series of statements, right? But look, guys, we have run out of time. Somebody has asked, how does this fit with CIMSPA and leisure operators? And that's a UK-based question, but I hesitate to. I don't know if you quickly want to speak to that, Andy, or should we?
I can quickly answer that. Yes, obviously, specialist exercise instructors in the UK are professionals in their own right, that they're not just personal trainers or fitness instructors. And with the CIMSPA transfer from reps, I just had we had a teleconference this morning. We are actively trying to look after specialist exercise instructors in the UK. Whoever might be dealing with them, we need a body to look after that profession.
Okay, yeah, lovely. Thank you. Yeah, so I think on that note, I will have to conclude. I could talk about this a lot. It's fantastic to have the input of Francis and Cade with those two more developed models that we have. And I really appreciate the time you've given to this gentleman. Sorry, Cade, that our signal was a bit patchy. But very much you put across the message there, and I can see how well developed that accredited exercise physiologist role is in Australia. I mean, that's a great model, right, Kate?
Yeah, look, it's like a lot of hard work and some good luck to get where we are, but we're really interested in aligning. You know, it's really exciting for us to see the UK and hopefully, you know, other areas in Europe evolving. I think that's the internationalization of the profession, as Francis talked about. I think is the next big challenge for all of us.
Great. Okay. Well, I hope that we will all talk again, because I think we're all working in a very similar area here with very similar intentions, yeah, I look forward to meeting and talking with you all again in the future. But thanks for today. Thanks for your contributions. Fantastic. I hope that's provided our audience with an interesting insight into this role, this higher level role, which I think, particularly in the light of COVID-19, is going to be even more valuable to us as a profession. Okay, so I think we will wrap it up there. Thank you all for your time, and we'll see you again soon. Okay, thank you guys. Thanks, Cade. Thanks, Francis. Thanks, Andy. Great stuff.